Long name.
I hope that I was able to pronounce correctly.
Long name, I'm very Greek. Thank you for the invitation. I'm emergency physician too, and I'm the chair of the ultrasound section of the European Society of Emergency Medicine. So the first part of my lecture is my expertise. No conflicts. As we know, it's very important to identify, to understand the different acute heart failure phenotypes, but not only to understand, but to identify them upon presentation in the emergency department. And this is already noticed in both of the previous guidelines of the European Society of Cardiology and the current ones. And also, it's highlighted that we can use both ultrasound and biomarkers in order to identify these phenotypes during the initial diagnostic workup in the emergency department of all these patients with acute heart failure. Let's start with point-of-care ultrasound. This is a very valuable tool in order to identify the different phenotypes. And now it's widely used in all emergency departments, and not only in the emergency department. So what we can do with different imaging modalities, we can combine our results and our findings in order to have a non-invasive assessment of cardiac structure and function. Also, we get information about systemic hemodynamics, and we can assess elevated venous pressure and check for extravascular fluid in the lungs. Regarding lung congestion, we know already we have so many studies on this topic, and what we know is that in the acute heart failure setting, it has an extremely high diagnostic value. It has a great sensitivity and specificity, and also it's a rule-in tool and rule-out for other conditions which mimic acute heart failure. Also, it has a prognostic value at discharge, because we can identify residual congestion and accordingly tailor our decongestive treatment at home. And also during hospitalization, we can monitor our treatment, optimize our decongestive treatment according to our lung ultrasound findings. But it's not only lung ultrasound. This is one part of what we can do with ultrasound. And we can combine the internal jugular vein findings, the B lines, as we said, the lung congestion, and to assess the renal venous flow all together. With all of these, we can put them all together and improve our decision-making and tailor our treatment, decongestive treatment. And here we can see, in a recent review of the European Society of Cardiology, how good are these tools, these sonographic modalities. Lung ultrasound has a great diagnostic value. As I said, it correlates very well with natriuretic peptides and with invasive cardiac hemodynamics. For the other modalities, we don't have many studies, so we don't have good results so far, but definitely they have a good prognostic value. Of course, we have to keep in mind their limitations. Now, to move in combination as an additional tool, we have biomarkers which are involved in different pathophysiological pathways in acute heart failure. So there are so many, and every day we have more and more. Some of them are well studied, some of the others are under investigation. Where we can use it, use them in the setting of acute heart failure as diagnostic tools, as prognostic tools to assess congestion, and of course, as we said before, in shock for DP3. Regarding natriuretic peptides, we discussed already so many times. We have many studies for many years. Our knowledge is well established, so according to the guidelines, they are a recommendation for the American guidelines, recommendation 1A as a tool for decision-making upon presentation in the ED. In the latest European guidelines. It's a recommendation 1B as a rule-out tool. And let's see some other biomarkers. Due to the time limitations, we will discuss a few of them. As we know, in acute heart failure, we have systematic inflammation. The team of Christian Mueller studied interleukin-6, one of these biomarkers. And what they did, they divided the different acute heart failure phenotypes, and they found that in a large population, something like 2,000 patients, they found that concentrations of interleukin-6 were highest in patients with cardiogenic shock compared to those with hypertensive acute heart failure. And and importantly, this biomarker is a strong predictor of 1-year mortality. So we have one study focused on different phenotypes. Most of the studies are in general about acute heart failure. They don't focus on different phenotypes. This is one of them. Another one, recent one, compared patients with de novo acute heart failure and patients with decompensated acute heart failure. And what they have shown that there are differences in key biomarkers, not the inflammatory biomarkers, but biomarkers for perfusion, speaking about lactate, and especially it was statistically different, significant at discharge, and congestion biomarkers like natriuretic peptides, and they found that even though they had a small population of 250 patients, they found that there are differences between those two phenotypes. A few years ago, we had this publication coming from the GREAT network about proenkephalin and its correlation with renal dysfunction. We know already that PENK levels reflect cardiorenal status in acute heart failure, and what they have shown that in patients who experience worsening renal function during hospitalization, the levels at discharge during hospitalization were worse compared to those on admission. And this was the difference between those who didn't have renal worsening during hospitalization. Also, it's a great prognostic marker for in-hospital mortality and mortality during follow-up. And in the same line, Professor Parisi's team started a study which is in progress. Here are the preliminary data. We measured the PENK upon presentation in the ED by using a point-of-care system with whole blood. So the results came out in 15 to 20 minutes after presentation in the ED in acute heart failure patients. And in order to check what's the role of this biomarker in the worsening renal function. And what we have shown that they are positively correlated with creatinine, log creatinine, lactate, pro-BNP, and troponin, but most importantly, it's associated with increased worsening renal function and is the strongest predictor of mortality. We measured it after 48 hours during hospitalization, and so far we have seen that we can use it as a predictor of worsening renal function, and what we can do, we can adjust, we can adapt our treatment, the congestive treatment, according to these findings. So upon presentation in the ED, we have an additional tool in order to decide how much we will treat the patient, how aggressive we will be or not. In summary, we can talk for hours for biomarkers. This is a very nice summary of the existing biomarkers coming from the European Society of Cardiology. We already talked about natriuretic peptides. CA125 is an old biomarker. We know it from many diseases and from cancer. It represents the pulmonary systemic distribution, and it's a marker of congestion. It's widely available, but still we need large-scale studies in order to put it in our everyday practice. About biodernomedulin, again, we can identify congestion and the residual congestion. It's a systematic, it represents systematic distribution. It's not widely available. Soluble ST2, again, it represents pulmonary systemic distribution, and it's useful for risk stratification. CD146, it's again represents venous congestion and is a marker for this. Again, it's not widely available. And hemoconcentration, we know it many years. It's easily, we can assess easily and interpret these results. And again, we can, with this, maybe it's helpful to interpret kidney function during the congestion. So, in summary, we have tools in order to improve our decision-making, in order to tailor our decongestive treatment for those patients, and to improve our phenotyping, we can say. So together with natriuretic peptides, we can use some circulating biomarkers in order to identify which is the predominant phenotype of congestion. Some of them are useful for monitoring and guiding the congestive therapies, but we need further studies in order to determine which of these can we can put in a multi-parametric approach, probably a score, multi-parametric score, in order to assess congestion. Thank you.
Thank you. Thank you so much, Effie. It's really interesting talk, coupling point-of-care ultrasound with
biomarkers. If I can start just to ask you, if you have just money for 3 biomarkers and just point-of-care ultrasound, in order to have therapeutical implication, which you would like to choose? You know, you have shown a lot of biomarkers, but which are the most that are giving you therapeutical implication?
In the emergency department?
Of course.
A part of ultrasound.
Yeah, ultrasound is there.
Okay. Definitely natriuretic peptides.
Okay.
We can use them, and now probably they are more cheap than before. These point-of-care systems, I think, are very useful because you can have the results in a few minutes. So probably promising, I can say promising, not something established. PENG will be
proencephalin, you mean?
Yes. Yes,
and
bioadrenomedulin, probably.
Yeah, that's also because Rinal showed that enibacimab should be a therapeutic option. Thank you. Yes, Martin.
Yeah, thank you for this nice overview, and I would like to support the idea that ultrasound is immediately available within seconds. And I mean biomarkers, so if I measure PENG, I need maybe 1 day or so. And the beauty and the challenge of acute heart failure is that it's acute. So what is your perspective on modern biomarkers which may be promising but not available in the situation where you see your patient?
Which? Can you repeat, please?
Yeah, so the question is, I mean, this new modern biomarkers, if they are not acutely available, you cannot measure them acutely at nighttime, on Sundays. So how can we prospectively incorporate that into our diagnostic algorithms? Because the acute heart failure is, let's say, there are the first 12 hours.
Yeah, Martini, she was showing point of care.
Yeah.
She was showing that these biomarkers are available point of care.
Exactly.
Yeah, but
point of care.
Okay. Okay, question other way around. I mean, so even at Charité, it's a big hospital here close in Berlin. I'm not available to have a point of care staff which, let's say, runs point-of-care assays according to the rules and legal rules we have. So you would need a kind of a satellite lab or something like that? Or do you think that these markers will be available on fully automated, no maintenance, centrally integrated systems, and which systems are that?
I think in order to answer and give precise answer, we need more studies about cost effectiveness. I'm not ready to say what are we gonna do in this case. Definitely, I will support ultrasound.
Okay, there's still room for discussion in the future. So thank you very much again, and now we leave the podium for the